revise and revisit the concepts of benign ovarian tumors. After that, we will be having another lecture series for pathological ovarian tumors and non-epithelial malignant tumors as well. So first and foremost, I would like to present a case where a reference consultation comes from surgery ward, and they admitted one 23-year-old female with acute pain in the right side of abdomen. She complained of nausea and vomiting, and she was not feeling well since morning. She was given symptomatic treatment, but there was no relief. And her last menstrual period was 10 days back. And ultrasound showed a right cystic mass around 8 by 8 centimeter. So the thing is, what is the differential diagnosis in this case? So when we have, based on clinical features, if we see the pain was presented on the right side. So the first differential diagnosis along with ovarian cysts that becomes in this case, which presented with nausea and vomiting as well, is that of acute appendicitis. Second confusing point was her LMP was just 10 days back. So would we be suspecting an ectopic pregnancy in this case? So answer should always be yes. A urine pregnancy test should always be done in reproductive age group, irrespective of her last menstrual period, because many times what we miss in such cases to ask about the pattern of bleeding, and many of times it is revealed that bleeding was not much, it was just scanty or spotting, which the particular patient, she mistook it for a period, and it could have been just a implantation bleeding or a case of ectopic pregnancy. Now, other further investigation that we will be doing in this case to rule out other pathologies are ultrasound. So in case of 8 by 8 centimeter cyst, a good examination would almost reveal what the pathology is like. So 8 by 8 centimeter ovarian cyst, especially if it was ruptured or torted, we would see a lot of guarding rigidity and tenderness in that area. Now, the clinical differentials that we have in this case is acute appendicitis, ovarian cyst rupture, ovarian cyst torsion, and a ruptured ectopic pregnancy case. And the first and foremost investigation apart from CBC will be TLC, ESR, a pregnancy test, and other ancillary tests. So in this case, emergency laparoscopy or laparotomy, what should be preferred? I would like to have an answer for this. A case with suspected torsion of ovarian cyst, what should be the ideal management protocol, going for a minimal invasive approach or an open one? So, okay. So nowadays, we can go for laparoscopic route also. There we see, first we confirm the diagnosis, and then we can proceed with removal of cyst, that is cystectomy. And in very many cases, we can do ovarian preservation also. It's not necessary to remove ovary or do an oophorectomy. So this is how something, a twisted ovarian mass looks like. And in this particular case, the twist was 3 times on the pedicle, and untwisting was done and cystectomy was performed. Her ovaries were fine. We could identify ovarian tissue in that patient, and ovaries were preserved. Both the sides, obviously. The second side was also inspected. Now, second case was a 24 years recently married, and she came with history of severe dysmenorrhea. She had one ultrasound which showed 5 by 5 centimeter complex ovarian cyst with ground glass appearance. And a doctor from her local area got her CA-125 done, which was elevated. It was in the range of 75. And she was advised surgical removal of this cyst, and they came for second opinion. So in this particular case, what should be the clinical diagnosis? Patient is having severe dysmenorrhea, an ultrasound showing ovarian cyst with classic ground glass appearance, and CA-125, which is not conclusive but supportive for endometriosis. So now she was advised a surgical removal for this cyst, and she was just recently married. So she wanted to avoid this operation. So she came for second opinion. So the question to the house is, what is CA125? What is the other differential diagnosis of this case, and how will we manage this patient? CA125 is a high molecular weight protein used as a marker for ovarian carcinoma, especially epithelial one. And it is expressed by epithelial ovarian tumors and benign and pathological conditions of Mullerian origin. Its physiological function exactly is unknown, but it is elevated in certain non-ovarian cancers like endometriosis and endometrial carcinoma, pancreatic carcinoma, lung and breast cancer, colorectal cancers, and other GI tumors, but it is quite non-specific and it should not be used as a standalone test to make a or refute a diagnosis of these conditions. It is also elevated in certain benign conditions like follicular phase of menstrual cycle, cirrhosis, hepatitis, endometriosis, pericarditis, and early pregnancy. So it is not useful in a screening for ovarian cancer in asymptomatic population because it is very famous and favorite with quite many of us. So the treatment, as we were discussing for this particular case, could have been a medical management of dysmenorrhea, observation for cyst size by serial ultrasound, and if patient does not conceive by 1 year, investigation for infertility. And if other associated comorbidities are present, we can pursue fertility investigation earlier, but as per the protocol, we need to give them 12 years of unprotected sexual intercourse. And if there is no pain relief even after medical management, then she can go for fertility enhancing one-time laparoscopic approach where her tubal evaluation, cyst evaluation, grading of endometriosis can be done at one point of time only. So what is an ovarian cyst? As we have seen two cases where there was a large ovarian cyst which twisted, and there was one small ovarian cyst which was so painful that patient had to come to a doctor. So what actually is an ovarian cyst? It is a semi-solid or fluid-filled sac within the ovary. So we can see ovary over here and one ovarian cyst or fluid-filled sac which is attached with ovary. Types of ovarian cyst are two. One is functional, other is pathological. When we look at the causes of pelvic mass by approximate frequency and age, from infancy to prepubertal, adolescent, reproductive, perimenopausal, and postmenopausal age, we see that functional ovarian cysts are the commonest one until reproductive age group. After that, fibroids, and in postmenopausal females, it is ovarian tumor, which occurs more in frequency. And in infancy, if we find malignant ovarian tumor, they are more likely to be germ cell tumor, both in infancy and pubertal stages. And after that, epithelial ovarian tumor in perimenopausal females takes over. So in adolescent age group and in reproductive age group, if we see epithelial ovarian tumors are the last ones to be considered, or they appear in lower frequency as compared to benign the cyst and functional cyst. And yes, obviously for a mass, pregnancy becomes the first differential in adolescent and reproductive age group. So when we talk of functional ovarian cyst, because they are the commonest one, and we find them quite commonly during our OPDs. So functional ovarian cysts are the cysts that develop as part of menstrual cycle and are usually harmless and short-lived. And these are the commonest type of ovarian cyst. Whereas pathological ovarian cysts occur due to abnormal cell growth, and these are less common than functional cysts. So let's discuss functional ovarian cysts today. We know the germ lines that an ovary is consisting of. It is consisting of surface epithelium, sex cord stromal cells, germ cells, inclusions. Cysts can also form, and other cysts like endometriosis and endometriomas can also form in an ovary. So what is the function of ovaries? First and foremost, if we revise back, It is production of estrogen from follicular cells. Then these follicular cells are recruited to form one dominant follicle. This dominant follicle then ovulates, becomes corpus luteum, and produces progesterone. So basically, this is a cycle which is going on. First, from primordial follicles, primary follicle is formed, which is forming finally a mature Graafian follicle containing oocyte, which is released during ovulation, subsequently forming corpus luteum. And in this cycle, till here, the cells are producing estrogen, and after this, cells are producing progesterone. So estrogen, which is produced during this phase, proliferates the endometrium and prepares uterus for pregnancy. And progesterone during this phase supports pregnancy if it occurs. So if there is no pregnancy, then estrogen plus progesterone withdraw themselves, and thus the patient or we all are having menstrual bleeding episode during that time. So to understand what are the types of functional ovarian cyst, there are 3 types of functional ovarian cyst. One is follicular, second is theca lutein, and third is corpus luteum. So functional में ही तीनों को याद करने का एक मतलब छोटा सा I have formed this. We can remember F for follicle, C for corpus luteum, and T for theca lutein. So, and if we remember like this, F for follicular, C for corpus luteum, ये दोनों menstrual cycle में बनती है. So, as we have seen here, यहाँ पर follicular cells का recruitment हो रहा था. So, during this phase, follicular cyst will form. And if we see over here, यहाँ पर corpus luteum बन रहा था, तो यहाँ पर corpus luteal cyst बनेगी. So, during follicular phase or proliferative phase, follicular cysts are more common, and during this secretory phase or luteal phase, corpus luteal cysts are more common. Now this third one, that is theca lutein cyst, I'll explain a bit later. So जैसे menstrual cycle advance करती है, तो first follicles are recruited, a dominant follicle is formed. Sometimes there is no ovulation or there is parallel recruitment of 2 large follicles. This follicle, if it is not rupturing, it leads to formation of entrapment of lot of fluid, and thus a follicular cyst is formed. And as we can presume and understand from this, कि ये सिर्फ follicular phase of this cycle में ही last करेगा. Probably by the end of this particular cycle, this should wane off. And if it is not waning off or decreasing in size in this cycle, it should decrease in size or completely disappear in the next menstrual cycle. अगर पेशेंट आपके पास आती है ल्यूटियल फेज में, यानी कि ओवुलेशन हो गया, उसको 25th, 27th, 26th डे है, 27th डे है, शी इज कंप्लेनिंग ऑफ स्लाइट पेन, यू गॉट एन अल्ट्रासाउंड डन, and there the sonologist reports that there is enlarged corpus luteum cyst, then we must understand कि यहाँ पे भी ovulation नहीं हुआ होगा या entrapment of cells हुआ होगा यहाँ पे, और जो corpus luteum एक fluid secrete करता है along with progesterone, that is entrapped inside it, and thus corpus luteum cyst has been formed. And the fate for this corpus luteum cyst is also the same. It should wane off during this menstrual cycle. If it is not, if it is persisting, then maybe after 1 or 2nd menstrual episode, it should go off. So, how do we look at the cyst? अगर हमें अल्ट्रासाउंड में किसी ने बोला है कि ओवेरियन सिस्ट है, ओवेरियन मास है, या एडनिक्सल मास है, या पेल्विक मास है, तो व्हाट शुड बी आवर फर्स्ट एम? फर्स्ट एम की ये है कि हमें पता करना है कि ओवेरियन ओरिजिन का है या नॉन ओवेरियन ओरिजिन का है, एंड दैट इज क्वाइट नाइसली given by radiologists because they see from where this particular structure is deriving its blood supply from, और वो कलर डॉपलर डाल के पता चल जाता है कि ओवेरियन है या नॉन ओवेरियन है. Second is we have to identify whether this is a benign cyst, functional cyst, or pathological cyst. So we see ultrasound pattern. सिंपल cyst है जिसमें पतला सा सेल वॉल लाइनिंग होगा और क्लियर फ्लूइड होगा. हेमरेजिक cyst है जिसमें कि एक ब्लड क्लॉट बीच में बैठा हुआ होगा एंड दे विल रिपोर्ट it as a case where a retracted blood clot has been found inside the cyst. Third will be endometrioma, which is classically having a ground glass appearance on ultrasound. Then there comes mature cystic teratoma, which is also known as dermoid cyst. There, the cynologist can find fat content, hair, tooth, bone, or anything that is quite heavy also. And it is diagnosed to the tune of 99% during ultrasound. और अगर और कुछ होता है देन पॉसिबली मैलिग्नेंट, फॉर विच वी विल डिस्कस कि मैलिग्नेंट ओवेरियन सिस्ट के फीचर्स क्या होते हैं. सो अगर ये फंक्शनल ओवेरियन सिस्ट है तो इसको हम फॉलो अप विद अल्ट्रासाउंड करते हैं. और अगर दूसरे टाइप को ओवेरियन सिस्ट है या जहां पर भी डायग्नोसिस इन डाउट है वहां पर हम मैग्नेटिक रेजोनेंस इमेजिंग कर सकते हैं. और अगर इंडिकेटेड है उन केसेस में एक्सप्लोरेटरी लेप्रोटमी जैसे कि torsion या फिर rupture हुआ. So when we see simple cysts, we can classify them into low risk and high risk category. Low risk cyst का size simple cyst less than 3 centimeter. और अगर इसमें एक simple cyst है less than 3 centimeter का किसी भी अल्ट्रासाउंड में we need not mention it. उसको हम बिना मेंशन करे भी भेज सकते हैं because it leads to unnecessary increase in anxiety for the patient. एक ओवेरियन सिस्ट सिंपल सिस्ट है 3 to 5 सेंटीमीटर की, इसमें मेंशन करना जरूरी होता है. और ऑलमोस्ट ये 3 to 5 सेंटीमीटर वाली सिस्ट जो कि उनका कंटेंट भी क्लियर है, थिन वॉल्ड है, तो सर्टेनली बेनाइन होती है. नाउ व्हाट इफ द साइज ऑफ द सिस्ट इज 5 to 7 सेंटीमीटर. इनमें अल्ट्रासाउंड से फॉलो अप करना होता है. इसमें ईयरली फॉलोअप लिखा है बट यू कैन गो इन फॉर मोर फ्रीक्वेंट फॉलोअप्स बिकॉज यूजुअली द पेशेंट्स आर quite anxious. And if a simple cyst, however benign or simple it is, if it is more than 7 centimeter, then you evaluate such a cyst with further investigation like CT scan or MRI, or you can directly go for surgery in such cases. High risk patient agar hai, we'll skip this. So I hope this particular diagnostic approach is clear because I don't want to confuse it with high risk over here. So let's revise. Pehla, less than 3 centimeter hai, simple cyst hai. We don't mention in it ultrasound, but usually we see a reporting for this. 3 to 5 centimeter का simple cyst है. ये follow up कर भी सकते हैं 3 to 5 centimeter में, and just like as I have told, ये resolve कर जाते हैं. 5 to 7 सेंटीमीटर का है तो आप इसको ईयरली 6 मंथली 3 मंथली फॉलोअप कर सकते हैं. और अगर सिंपल सिस्ट मोर देन 7 सेंटीमीटर का है तो इसको फर्दर इवैल्यूएशन बाय एडवांस डायग्नोस्टिक मोडालिटीज और सर्जरी परफॉर्म कर सकते हैं. सो व्हाट आर द फीचर्स ऑफ फॉलिकुलर सिस्ट? ये 3 to 7 सेंटीमीटर तक ही होंगी, rarely larger than 8 centimeter. These are the commonest in frequency, and they are associated in people who are either smoking or are exposed to smoking. Diagnosis usually by ultrasound. Treatment में कुछ नहीं करना है, expectant management करना है. इनका complication patient को हमेशा बता के रखना चाहिए कि अगर 5 to 7 centimeter की range में है, then patient can have torsion or rupture, and we have seen torsion of ovarian cyst in as small as 4 to 5 centimeter also. So one thing that you should always remember and tell your patient is that if she has been diagnosed with an ovarian cyst, 3 to 5 centimeter में कुछ नहीं, but more than 5 centimeter में, she should be explained that in case she is having a sudden unbearable pain, there is fainting episode or anything like that, she should report to emergency room immediately. Second was corpus luteum cyst. It is less common because it commonly ruptures and may cause hemoperitoneum. Often right side पे ज़्यादा होती है. This is just an observational finding and no specific cause was seen for that. और इनको रप्चर होने का टाइम बड़ा स्पेसिफिक सा होता है, दैट इज डे 20 to 26. नाउ व्हाट हैपेंस, एज आई डिस्कस्ड अर्लियर ऑल्सो, कि 20, 25, 26 दिन पे एक पेशेंट आएगी कि बहुत तेज सा पेन हुआ है, पेशेंट का अल्ट्रासाउंड होगा, उसमें थोड़ा सा वो बताएंगे कि पेन है, थोड़ा सा ब्लड इन द पेरिटोनियल कैविटी पाउच ऑफ डगलस में मिला है, और फौरन एक डिफरेंशियल दिमाग में आनी चाहिए, दैट इज एक्टोपिक प्रेगनेंसी. In fact, ruptured corpus luteum cyst is the commonest differential for ruptured ectopic pregnancy. So in this case also, if you are sure that this is a case of corpus luteum cyst which has ruptured or unruptured, you just have to give a supervision for pain if at all it is occurring, and treatment is observation, and we don't remove these cysts, neither follicular cyst nor corpus luteum cyst, surgically until unless there is an indication. नाउ थिकर ल्यूटीन सिस्ट, ये लीस्ट कॉमन है फंक्शनल सिस्ट में. इनका एक खास फीचर है कि ये यूजुअली बाइलेटरल होती है, because they are forming universally in response to excessive beta HCG stimulation. So these are more common with excessive beta HCG situations like twin pregnancy and molar pregnancy. So beta HCG is circulating in the entire body. These cysts are ovaries are overstimulated by excessive beta HCG. That is why they will be having a bilateral appearance. On ultrasound, we can see multiple cysts which are having thin septations present bilaterally. A pregnancy is there, either a molar pregnancy or a twin pregnancy, then we should always suspect that we are dealing with a case of theca lutein cyst. So what is the treatment for theca lutein cyst? Nothing until unless there is an emergency condition. They usually resolve after pregnancy if it was a case with twins. And as soon as you remove the molar pregnancy, you evacuate it, then also within 4 to 6 weeks, they resolve completely. So they resolve in parallel or proportion to the decline in beta HCG values in the serum. So let us revise few things before we proceed further. The commonest type of cyst that you will see across puberty, infancy, and reproductive age group will be functional ovarian cyst. So what are functional ovarian cysts? They are nothing. They are the cysts which have been formed due to either overproduction, oversecretion, or overstimulation by certain hormones. There are three types of functional ovarian cyst. First is follicular, which is forming in the follicular phase of ovarian cycle. Second is corpus luteal cyst, which is forming during the luteal phase of menstrual cycle. And third is theca lutein cyst, which is least common, having a specific feature of being present bilaterally. And this is forming in response to excessive beta HCG stimulation, especially with molar pregnancy. तीनों तरह की cyst को ट्रीटमेंट के लिए सिर्फ ऑब्जर्वेशन एंड एक्सपेक्टेंट मैनेजमेंट चाहिए, अनटिल एंड अनलेस उनका साइज 7 सेंटीमीटर से ज्यादा हो, जो कि बहुत रेयर है, या फिर उसमें किसी भी वजह से रप्चर या टॉर्जन, then only we need to give a surgical thought to these cysts. Otherwise, these cysts usually resolve in 2 to 3 months time or within the first menstrual cycle itself. Sometimes we may see, so here I wanted to discuss one important point also. We have usually seen a common practice of prescription of oral contraceptive pills as a treatment part for functional ovarian cyst, especially corpus luteum cyst and functional ovarian cyst. So do these OCPs, oral contraceptive pills, have any role in treating or resolving these functional cysts? तो ये तो पक्का है कि प्रेगनेंसी वाली सिस्ट यानी कि थिका ल्यूटीन सिस्ट में हम ओसीपी नहीं दे रहे. सो हम ओसीपी अगर दे रहे हैं तो सिर्फ फंक्शनल फॉलिकुलर और कॉर्पस ल्यूटियम सिस्ट में दे रहे हैं. तो वहां पे एक बात बड़ी क्लियर होनी चाहिए कि ओरल कॉन्ट्रासेप्टिव pills will not decrease the size of these present cysts that you are seeing now. these OCPs, what will they do? They will prevent the recurrence of cyst. अभी OCP अगर आपने दिया तो ये फॉलिकुलर सिस्ट या कॉर्पस ल्यूटियम सिस्ट तो खुद ही डाई आउट कर जानी है. तो जो ओरल कॉन्ट्रासेप्टिव पिल आप दे रहे हैं वो इसको रिजॉल्व करने के लिए नहीं दे रहे हैं, क्योंकि ये खुद हो जाएगी. अगर आप दे रहे हैं तो इसलिए दे रहे हैं ताकि सब्सिक्वेंट साइकिल्स में इस तरह की फंक्शनल सिस्ट ना बने. सो इफ एट ऑल योर एम इज टू प्रिवेंट, स्पेशली कई सारे पेशेंट्स आते हैं कि उनको रिकरेंट फंक्शनल ओवेरियन सिस्ट होती हैं, बड़े परेशान रहते हैं, बार बार अल्ट्रासाउंड कराते हैं, तो उनमें यू कैन गिव अ ट्रीटमेंट फॉर 2 to 3 cycles backed up by oral contraceptive pills where they will prevent recurrence but not resolution of the current or present cyst. So this was all about simple ovarian cyst or functional ovarian cyst. If I have time, I can discuss. In next class, we will discuss about pathological ovarian cyst. And the questions that we have to remember for today are: 1. What are the commonest types of ovarian cyst seen from infancy to reproductive age group? पहला. दूसरा है कि what are the 3 types of functional ovarian cyst? तीसरा है what is the type of functional ovarian cyst which is seen during pregnancy? चौथा है what is the treatment for functional ovarian cyst? पांचवा है in which condition should we give a surgical thought for functional ovarian cyst? So if we have any questions, we can take up them here. So thank you so much for being with us. We'll discuss pathological ovarian cyst in the next class. Thank you.